And our next presenter is here from Washington State. We're very lucky. I've tried to get Chas Debolt up here in prior years, and this is the first year that I was successful. I think she needs a break from coronavirus. So we're very fortunate that she's here to talk to us about the experience in Washington State of the measles outbreak that occurred last year and related policy implications. Chas has been a senior epidemiologist for vaccine-preventable diseases at the State Health Department for the past 15 years, and before that, she worked at the Seattle and King County Communicable Disease Epidemiology and Immunization section. I email with Chas, and I'm on the phone with her, and she and I've been invited to the U.S. Measles, Mumps, Rubella, Varicella group that teleconferences about quarterly to discuss very timely issues to deal with the management of those 4 diseases, and I really benefited from that process and the knowledge that Chas has been able to impart based on their experience. So Chas, welcome to the meeting, and thank you very much for coming.
Thank you, Monica. It's great to be here. Good morning, everybody. I'm one of those people that figures if I've got 20 minutes, I'll have 50 slides. So we're going to go fast because I always have lots to say. And we've had last year was a really interesting year for us with measles. So I want to talk to you a bit about our measles outbreak. I'm trying to decide, okay, I'm going to watch here instead of turning around. So prior to January of 2019, we had 7 required vaccinations for childcare and 5 for school entry. And we allowed a personal belief, personal philosophical belief exemption, religious and religious membership exemption, and a medical exemption for each of the vaccines. And our school immunization exemptions for students, this graph just shows you the types of exemptions that are claimed. Very few medical exemptions, but in total, because of non-medical exemptions, our exemption rate in schools is overall about 4.8% of students claim an exemption. And it's important to remember that this is to 1 or more vaccines. It isn't all vaccines, but 1 or more vaccines is what that statistic is. Our rate of immunization for kindergartners prior to 2019, the line is showing 1998 to 2019. And you can see it runs a little, the coverage, completely immunized, runs a little over 80% up to 86 or so. When I first started in public health, our MMR immunization rate in King County was 95% or more, and that was in the early 90s. This shows our state by immunization exemptions, and the red are high rates of exemption, and the green are low rates of exemption. So it just gives you kind of an idea of the mosaic in our state. We have little pockets, and is this a pointer, or is that back? Do we have a pointer? The small green button. Ooh. The one with the star on it, maybe? The star, okay. Okay, so the area that I'm going to be, thank you, the area that I'm going to be talking about where the measles outbreak happened is down here. And Portland is right about where the green button is, so Seattle's up here. So it's a real patchwork in Clark County where the measles outbreak occurred. And then I have Clark County, this is Clark County itself. Vancouver is down in this area, but in the suburbs of Vancouver, there are definitely some pockets of low immunization rates. So, and you can see that that's as low as 50%. Actually, 59. Oops. Okay, so if you look at measles in Washington State, our state epidemiologist made this graph during the measles outbreak because we wanted to just get a long-term perspective on really what the measles incidence has been in the past. So you can see that until the vaccine was introduced in the mid-60s, we had tens of thousands of cases every year. But beginning in the 60s, the current vaccine in use in the United States was licensed in 1968, and we had a precipitous drop in measles cases. And then if you look, because the rates are so low since the introduction of the vaccine, if you look from 68 to the present in the inset, we've had a couple of outbreaks, but pretty much we have very low incidence. Measles is very contagious, and I think it's really interesting to look at this right now. What we're being told about coronavirus is that it is approximately the R0, or the number of people that you will make sick if you get the disease, if they're susceptible, is about 2, and that's what we're being told, 2 to 3 for coronavirus. Look at measles, the arm, excuse me for that, I just got you in the eye. The measles is about 18, so super contagious. And if somebody is susceptible and exposed, it's not if they'll get the measles, it really is when they get the measles. So the best prevention we have is vaccination. And I love this slide. The different boxes across the top, it's 0%, 25%, 50%, and then if you get up toward 75, 90, and 95%, you can see how a 95% coverage with vaccine really reduces the spread of measles. Well, why can't I just wear a mask? Because measles spreads easily. It is not just droplets, it is airborne. And measles will hang in the air and wait for a nose for up to 2 hours after the sick person has left. In Washington, measles is a notifiable condition, and what is reportable by law are suspect cases. So when a healthcare provider sees someone who he or she thinks has measles, that is reportable by law. So we don't want to wait. And when I first started in public health, we had a lot of problems with specimens going off to King of Prussia, Pennsylvania, or Burlington, North Carolina, and we'd have a week turnaround. And we only had serology. And so we'd have a lot of spread before we could confirm measles. But now, if we can coordinate with the healthcare provider right while the patient's in the office and transport the specimen immediately to the state public health lab, which is where I work actually in the lab, once we get the specimen in-house, we can turn that result around in about 4 hours. And so with that rapid turnaround, it gives us a chance to really work on prevention and even get prophylaxis to other people who've been exposed if it's within 72 hours of exposure. So the Clark County outbreak, the suspect case was reported on 12/31. It was snowing, and so we didn't get the specimen up to the state public health lab and confirmed until the 3rd. And the following weekend, I happened to be down in Portland with some family, and I got a call on a Sunday morning while I was drinking my espresso with my cousin, and the person on call said, I just got 11 calls, and they all really do sound like measles. And the next thing I knew, it was May. Oh, That wasn't on the slide. So Clark County went into incident command. These were all cases in Clark County on the 15th, and a team from the State Department of Health went down, and we had a presence there in Clark County into March, so a couple months of response. And actually, we had a declaration by our governor of an emergency because it was taking so many resources. And the last rash onset was the 13th of March. And so the outbreak, we wait 2 incubation periods to declare it over, so that's 42 days. So it wasn't declared over until the end of April. Clark County sent out a lot of provider advisories. And what we are looking for in a case investigation is, were they in a large public setting? Was a case at school while contagious? Were they in a healthcare facility while contagious? And managing measles exposures in clinics is always very intense. We look for babies under 1 and pregnant women who might need immune globulin. We make immediately, even before we confirm the measles as measles, we want a list of the people that will need to be contacted if measles is confirmed. And as I said, we have to not use the room for a couple hours after the case has left. And all staff should have documented immunity. And you know, we still find clinics where there's I didn't get around to getting that vaccination, and so healthcare personnel have to get furloughed if they were susceptible when exposed, and that's a tax on the system. So as I said, you can give MMR within 72 hours and immune globulin for unvaccinated pregnant women, infants, and severely immunocompromised people. And I do want to mention that in 2015, we identified in another measles outbreak in Clallam County, we identified a person who had been exposed but and did have some immunocompromised, but we obtained a serum and checked the IgG and it was positive. But long story short, in about 2 months, she presented with some vague symptoms and was actually discovered to have had measles pneumonia on autopsy. So with immunocompromised people, I think it's really important to involve the healthcare provider and talk about the need for immune globulin, even if you get a positive IgG that looks like they're immune to measles. This is our EpiCurve in Clark County, and I just want to point out that international travel, church, household, school or daycare, there were a lot of exposures. And I'm going to speed up now so that we can kind of go through this. So this is the age range. Most of the cases in this outbreak were school-age kids. Most of them were unvaccinated, and the majority was lab confirmed. And it continued to snow, and so Oregon Public Health Lab stepped up. It's right across the river. So it's a courier pickup as opposed to driving all the way up I-5 for 2.5 hours. So Oregon did a lot of our lab confirmation for us. So we had 72 cases, and all of them were Clark County except one guy who brought his son down to basketball tournament. And he was at one of those gaming places where you can play all kinds of different games one evening when some cases were in there and contagious. And he was a King County resident in his 50s. So this is just kind of interesting for those of you, I don't know how many of you do surveillance as well as immunization, but I learned in this outbreak that the serial transmission interval for measles averages about 11.7 days. And so when we had this many cases, I decided to try to apply it. And so assuming a serial transmission interval of 12 days, it's just really interesting how every 12 days we had a peak until we could get in and get people quarantined so that when they became contagious, they were not out in the public. And that is how you get an outbreak stopped. And I really believe it just took us a little bit to get our act together, but I think we had in this second peak here, well, it would be third, we had more cases than we needed because we weren't getting in fast enough. So Clark County did 4,000 interviews, sent 3,000 letters, monitored over 800 people. The point being, it takes a lot of resources to manage this. We had, whoops, I'm sorry, I think, yes. We had 54 exposure sites. There were 12 healthcare facilities, 15 schools, 1 child care, and 25 other public locations where people were while contagious. We had 5 school districts involved, and we had many students, like 700 or 800 students excluded from school. So outbreaks are a lot of work, and we ended up publishing an MMWR about the outbreak. But at the same time, there were outbreaks in other parts of the United States. And actually, the outbreaks in New York City and New York State were sustained from October of 2018 clear till October of 2019. And the United States almost lost our elimination status. That means it's really the duration, not the volume of cases, but how long you're having transmission. And if it's sustained over a year, same chains of transmission, then we lose that status as from World Health Organization as a country in elimination. And measles is just a plane ride away, we know that. And so the measles outbreak in Clark County was declared over on April 29th, and another outbreak started. And what we found out is right before we declared the Clark County outbreak over, we had a group of 7 cases with a common travel date of April 25th. They were all at SeaTac that day, SeaTac Airport. And so we actually had 14 cases, and then cases in at least 6 other states, all related to that SeaTac nexus. We never did find out who the index case was, who was super spreading at SeaTac. How are the outbreaks different? Well, in Clark County, as I mentioned, 72% kids. And in the SeaTac outbreak, it was 64% adults who were exposed in public settings. This second outbreak did veer into a hospital, and we had quite a few exposures, and there were cases among patients and staff at the hospital. So just pointing out that outbreaks are different and you have to have different strategies. And the state health department was in incident command for 71 days. We had 16,000 hours of staff time, and it cost about $1.1 million. And Clark County estimated that they spent $864,000 plus dollars on their outbreak. So total, it cost, between Clark County's cost and the state health department, it was over $2 million. And this is just for the first outbreak, the Clark County outbreak. So I think if you just remember the beginning of the Clark outbreak, on the 15th, they went into incident command, and our state legislative session started on the 14th. And so as this outbreak just blossomed, we had legislators that were saying, this is ridiculous, we don't want to spend this money, let's get some bills here, let's change this so we don't have all these exempted kids in the school setting. And as you remember from the slide about the schools, it really impacted the schools in Clark County. So 2 bills were introduced. One was to remove personal belief exemptions for all vaccines. And House Bill 1638 was to remove personal belief exemption for MMR only. And that is the one that passed and became state law going into effect this past July 28th. So during the session, we had an abundance of proposals. There was one, it's just interesting what gets introduced. When people talk with their legislators, those legislators really want to represent the people in their district, and so they will introduce bills onto the floor. One was they wanted to allow a medical exemption if a sibling has had an adverse event. So the sibling has an adverse event, and so the next kid can have a medical exemption. We had a lot of parent concern, and one bill wanted to allow parent input on a medical exemption rather than just have it be a physician or a healthcare provider's declared exemption. Child care, they wanted to exclude child care from the bill so it would only apply to K-12. And another bill wanted the Secretary of Health to be civilly liable for any damage done to a child's education by not being allowed in school due to removal of the exemption. We also had a lot of proposals to the State Board of Health, which is, it's different than the legislature, and our school entry law is actually under the auspices of the State Board of Health. One proposal was to remove pertussis vaccines as a requirement for school and child care attendance. And this is, if some of you are aware, acellular vaccine is not as effective as the old wholesale vaccine. And so the proposal was just take it out altogether for school attendance because it's not as effective as it should be. And it's possible, according to the person who introduced the rule, for asymptomatic people or people with unrecognizable pertussis to spread pertussis. And they don't get excluded from school anyway, was the concern. They wanted to, there was a proposal to implement new rules regarding use of an IIS, our Immunization Information System data, and they wanted to add new categories to the existing immunization status categories. And there was also a proposal to add HPV as a school requirement. So I'm getting a little bit close to the end of my time, so I don't want to dwell on this too much, but the rulemaking, the timeline that for the WAC, for the school entry, and as opposed to the legislative process, so there's a legislative process where the legislature tells us, okay, we're going to vote on this, and the legislature says, okay, we're removing the exemption. But then we have the Washington Administrative Code, which is how you implement the legislated law. So it took some time for us to work on making the changes. And so we do a lot of clarification and saying how the laws will be implemented in the advisory, the administrative code. So what we have now, we still require 7 vaccinations for child care entry, and for school entry, but now we do not allow a personal philosophical exemption for MMR vaccine. We still allow it for all of other vaccines, and we do have religious and religious membership exemptions. We are watching that to see if it is going up. We don't have good data yet because the school year just started in September. So it will be this school year where we're watching for any shift between the personal exemption and religious exemption. It does apply to public and private schools and licensed childcare. And childcare workers, we weren't able to do this for schools, but childcare workers must provide documentation of MMR vaccine or other evidence of immunity. So as I said, it went into effect this year, and we did develop a new certificate of exemption. We already had a certificate of exemption, and in Washington, to get that certificate of exemption, parents must have certification that they have sat with a healthcare provider and been educated about the benefits and risks of claiming an exemption. I think we have other speakers that will give you much more information on misinformation, but we really do have a lot of folks in our population in Washington who are what we prefer to call vaccine hesitant. They're concerned, they want to do the best thing for their child. There's a lot of information out there, especially on social media, that causes a new parent especially, they want to not do anything that might harm their child. And so we're working a lot on vaccine hesitancy, which is what we're focusing on here today. We are asking for support for technical assistance to schools, and we have developed a school module that is part of our immunization registry so that the school nurses have, it's more convenient for them to get the immunization doses and document whether a child has an exemption, whether a child is complete or not. Hopefully we'll get a little support from more school nurses. We're actually trying to put an immunization position in the school, in the state education agency. And we've asked for funding for prenatal outreach. Future legislation, we're wondering about the personal belief for other vaccines. We are keeping an eye on the religious exemptions to see if they're properly used. We are wondering about additional controls on medical exemptions and how they're certified. And we would love to have school personnel have to be immunized because when in outbreaks, I have had one situation years ago in a rubella outbreak where they had to close schools because they didn't have enough staff with documented immunity. They may have had the immunity, but they didn't have documentation of it, and they had to close the school down for 3 days to get documentation. So the last thing I want to show you is this is 12 months worth of measles genotypes. And it's really important to remember just how much measles there is in the world. And as I said, it's just a plane ride away. So just want to acknowledge my amazing colleagues at the Clark County Public Health Seattle King and Tacoma and Snohomish Health Districts as well. We just have a great crew in our local, we have 35 local health jurisdictions, and they've rapidly become measles experts over the last couple of years.